Hi, everyone. My name is Anoosha. I am a general surgery resident, and I'm doing my research time at the American College of Surgeons. Thank you for the opportunity to present our work on identifying quality improvement targets at a national level in G-tubes for pediatric patients. So the college chose to look at G-tubes in particular within peds because it's one of the most common operations done in pediatric surgery. At LPCH, it was 8% of operations performed in 2023. It also has been shown in the literature to comprise a significant amount of the morbidity in the pediatric surgery community, whether it be SSIs or readmissions or costs related to readmissions. And single institutions have had a lot of luck in improving G-tube specific morbidity outcomes from quality improvement targets. People have been able to successfully reduce their dislodgements, their ED visits, et cetera. But there really wasn't a way to nationally capture this information from a clinical registry. The ACS Pediatric NSQIP program collects general morbidity outcomes like SSIs, UTIs, MIs, but nothing specific to G-tubes. So that's why this pilot was rolled out. And this study that I'm presenting today analyzes the first available results from the NSQIP Pediatric G-tube pilot. It aims to identify national QI targets in first perioperative process measures with the widest practice pattern variation throughout the country, and the G-tube morbidity outcomes with the highest incidence. So there are a number of variables collected per the pilot: demographic variables, perioperative process measures, and postoperative morbidity outcomes. I've highlighted a couple to demonstrate today. It was a retrospective cohort analysis of the NSQIP pediatric database of pediatric surgical patients aged 0 to 18 who underwent G-tube placements in 2023. 45% of the NSQIP ped sites, so 70 sites, participated in the pilot, with a median of 61 G-tubes per site submitted. Now, we may be wondering which bar is LPCH. Unfortunately, LPCH did not participate in the pilot study, but the outstanding nurses from the surgical outcomes department at LPCH actually pulled this data for this presentation today, so we can get a sense of how the complications kind of stand nationally. So LPCH is highlighted here in the red. We'll start with perioperative process measures with preoperative upper GI use. So in the overall cohort, 45% of G-tubes had a preoperative upper GI study. Sounds like the flip of a coin, but when we break it out by hospital, we get a little bit of a different story. The proportion per hospital ranged from 0% all the way to 99%. The vertical axis is number of cases submitted to the database, and the sites are ordered from left to right based on increasing proportion of G-tubes that had these perioperative upper GI studies. So towards the left of the graph, we see that some sites are rarely doing routine preoperative upper GIs, whereas towards the right, it's basically a routine practice. The data shows that less than 4% of the time are these preoperative upper GI studies actually useful. So what it means is we're doing these studies a lot, incurring costs, incurring extra burden for patients, for potentially not a lot of change in operative management. So now what do we do with data like this? Do we say that any site that's doing these studies more than 45% of the time, do they just need to cut back or be penalized in some way? And not necessarily, because these are just proportions. They don't have any information about patient level risk factors, other reasons that clinicians may choose to conduct these studies in their patient populations. So the utility really is that an individual institution can take their relative standing compared to the rest of the hospital's home and ask questions. Ask whether it's a specific surgeon cohort that is routinely ordering these. Is it a specific patient population that's getting these? And if it is a specific patient population, does this deserve to be protocolized across the institution to standardize that practice? This is the data from our site. 27% of patients who underwent a G-tube in 2023 had a preoperative upper GI study. Moving on to concurrent fundoplications, across the cohort, about 4% of G-tubes had a concurrent fundoplication. The proportion here ranged from 0 to 58%, but we can visually see that the incidence itself is way lower, the proportion of variations is way more narrow, so maybe not as fruitful of a QI target at a national level than the preoperative upper GI study, the series. And at LPCH, 2.5% of the G-tubes last year had concurrent fundoplications. Looking at some post-op morbidity outcomes, 14% of G-tubes experienced a 0 to 30-day ED visit afterwards, and that proportion in hospitals ranged from 0 to 33%. And at LPCH, the rate was 19%. So almost 1 out of every 5 G tubes that was placed last year came back to the ED within 30 days. 0 to 30-day readmissions cohort rate about 3%, proportion 0 to 13%. Again, narrower proportion, lower incidence rate, maybe not as good as the national, not as fruitful for a first level national QI target. At LPCH, the rate was 9%. You may notice that this is 3 times the cohort rate and maybe wondering why. I'll just point out here that the methodology for sampling the cases was completely different to the cohort. So really the way to interpret our institution data is just to take those 14 cases in the numerator of that rate, potentially do some chart review, see if there are common themes and if it's worth prioritizing for a QI intervention. And finally, I have 0 to 60-day dislodgements. 9.5% of the cohort experienced a 0 to 60-day dislodgement. The important point I want to point out here is most clinical outcomes are measured out to 30 days, but listed here, the 31 to 60-day dislodgement extended follow-up period captured almost the same number of dislodgements as a 0 to 30-day period. And the important part of this is if a child has a G-tube dislodgement earlier on in their postoperative course, the tract may not be mature enough for that parent to be able to replace it at home, and it more likely will result in return to system for that patient. So just important to keep in mind that certain post-op morbidities may require more nuanced follow-up or extended follow-up. At LPCH, the rate was 20%. So at our hospital, 1 out of every 5 G tubes that was placed last year had a dislodgement. So again, just something to keep in mind and see if that's a relative priority for us to focus on. And I will say I was talking to some of the PAs earlier, and it sounds like it is. There are a couple of interventions that are happening right now to try to increase to some kind of an adhesive device that I have more to learn about to try to address dislodgement rates. So to conclude, the future G-tube QI targets that this pilot study identified were to standardize the preoperative upper GI utilization and decrease the 0 to 30-day ED visits and also dislodgements. And kind of just in conclusion, you know, there's so much we can learn from each other, from different institutions. A lot of institutions have been very innovative in how they've decreased some of these rates, but individually, it's difficult to find relevance in some of these things unless we have data that shows where we stand relative to others. Like what really is an acceptable complication rate or acceptable failure rate? How many dislodgements is okay, you know? So the data really helps contextualize things, but at the end of the day, each institution needs to take this information home and decide where it stands as far as relative priority for their context.